Assalamu alaikum wa rahmatullahi wa barakatuh. Hello and welcome everyone for tonight's online webinar. My name is Alia Ashawab, clinical nutritionist, bariatric care specialist, and the scientific committee chairperson at the Emirates Clinical Nutrition Society. I'll be your host for tonight, and I will be taking you through our informative webinar. Before we get started, I would like to give you a very short introduction about the society, which is hosting the webinar. It is a nonprofit medical society established in the year 2016 by the efforts of a group of clinical nutritionists concerned in the management and the amelioration of nutrition and diet of the communities in the United Arab Emirates. It serves to conduct continuous professional development activities, which enables nutritionists to update their knowledge and provide a common platform to network, and aims to reform the lifestyle of communities in the United Arab Emirates in order to increase productivity and encourage the communities to actively be a member in promoting healthy living. What do members of the society benefit? Information on the medical meetings and conferences which are being held locally and abroad as well, details of the CME programs and other announcements, quarterly Emirates Medical Journal, which features research papers and case reports written by local and foreign doctors as well, reduced rates and participation in all EMA activities, organized workshops, seminars, conferences, and webinars as well. How to be a member is very easy. Either direct registration through the Emirates Medical Association website, direct email, which you can see as well at the bottom of the screen. You can call on the direct telephone number you can see through Facebook, email, Twitter, as well as the Instagram. And moving on, a few housekeeping rules. Just be reminded that this webinar is being live streamed on the MCI YouTube channel. And if you have any questions, please feel free to type them in the Q&A panel that you can see in your control panel and mention the speaker's name and your question very clearly. We will be answering them by the end of the session. If you have any questions regarding the webinar itself, you can directly contact the WhatsApp number for the live chat support that's being seen on the screen as well. And also be informed that this webinar is accredited by the DHA with 1.5 CME. And without further ado, I would like to introduce our first speaker for tonight, who will be speaking about nutrition and wound healing, enhanced recovery after surgery, Dr. Ashraf Al-Houfi, who is a consultant head of the ICU department, chairman, infection control committee in Dubai Hospital. He is also the examiner for the Royal College of Physicians in the United Kingdom. Thank you very much, Dr. Ashraf, for joining us tonight. It's a pleasure having you here with us. The floor is all yours, and you can start with your presentation. Thank you.
Thank you very much, Alia, for this nice introduction. And thank you for the Emirates Clinical Nutrition Society for organizing such a beneficial webinars and for inviting me for this one. I will be sharing my screen, hopefully right now. I'm trying to share the screen, but it's a bit frozen. Can I have some technical help from our people?
1 second, doctor.
It was working very fine till you stopped sharing me.
Okay, I'm sure they're trying to help you out with that, Dr. Ashraf. And by the time we get that settled, I would just like to thank everyone who are joining us for the live webinar on the critical care management. We'd also like to thank our other guest speakers who will be joining us tonight, Ms. Afra bin Ketta from the Emirates Clinical Nutrition Society, and we're also having Ms. Sumaya Minan, a nurse from Hatta Hospital, and you will be also having a speech from Dinan Assami as well towards the end of the session, and we'll also be having a few announcements about our further coming webinars by the end of this month and the next, and I will be announcing that by the end of the session. Until our technical issue is resolved for Dr. Ashraf, it will be better to move on to our next speaker, Ms. Sumaya Minan, staff nurse wound care team in Hatta Hospital, who will be talking about pressure injury policy assessment, prevention, and management. Thank you very much, Ms. Sumaya, for joining us tonight. I'm sure we will be enjoying your presentation. The floor is all yours, and you can start.
Yeah, thank you, Ms. Alia. Can you hear me now?
Yes, you can start.
Okay, dear, I'll be just starting my video now. Good evening, everyone, and it's a very wide pleasure for me to share my screen with most of the specialists from the department, and I'm Soumya and the wound nurse from the Hatta Hospital and the DHA. And today the session will be about the pressure injury prevention, management, and treatment. Okay. Is this one visible, Alia? Miss Alia, you can share. You can see my screen now.
Yes, it's very clear.
Yeah. Okay, dear. Thank you. So, as I told you, the topic will be on the pressure injury assessment, prevention, and the management. It's a very wide topic actually, but I'll be going through a very brief sessions because, as you know, like the time restraints also we have. So the objective of today's my sessions will be what is a pressure injury, what are the increased risk factors, and what are the stages, and what is a device-related pressure injury and its prevention, and how we can access, prevent, and manage a pressure injury. So, as we know, before 2013, I remember we are telling it's a pressure ulcer, but as per the NPIAP guidelines, we changed it and it is now pressure injury. Before only we used to tell pressure ulcer, now it is pressure injury. A pressure injury is a localized damage to the skin or the underlying soft tissue, usually over the bony area or related to a medical or any other devices. The injury occurs as a result of the intense and or the prolonged pressure or the pressure in combination with the shear. This is as per the NPIAP guidelines. So as you know, wherever if we have a skin peel or a redness, it's not a pressure injury nowadays. It should be over a bony area, or if any medical device is associated with it or any other devices, then only we can classify it as a pressure injury. Because nowadays in our hospital settings, we used to be called by the other department, there is a pressure injury for a patient, just come and have a look at it. But when we go to it, it's not a pressure injury. That's what we're trying to educate nowadays. A pressure injury should be over a bony prominence or related to a medical or any other devices. And so what are the risk factors associated with it? There are two risk factors intrinsic and extrinsic. And intrinsic, as you know, the main concept of the pressure injury is if the patient is elderly, bedridden, so many comorbid factors are there, which contribute to the rise in the incidence of the pressure injury. And some of the intrinsic factors are the age, malnutrition, dehydration, systemic illness, obesity, urine or fecal incontinence, poor skin condition, level of consciousness, and the comorbid condition like ESRD or DM, hypertension, whatever the thing may be. So as we are in the hospital settings, we are now going through a lot of cases, and in most of the patients, most of them are elderly with a bedridden or the in adults also, if it's some bedridden due to some other medical conditions or something hemodynamic instability, there is a higher chance of developing the pressure injury. As you know, the pressure injury which develops during the initial stages can be healable. But if the stages are more, like if the stage is beyond 3 and 4, it's very difficult to heal and it takes a long time to heal. And that's what we are seeing nowadays. And so what are the external factors which contribute to the increase in the pressure injury? So there is two factors, like as I told in the definition, there is a friction and there is a shear. Like what is the friction? There's something rubbing contact between your skin and the surface material. That is called as a friction. As you know, it's a layman word. And so what is the shear? Like shear is something like it moves extra parallel to the surface of the tissue. That is a shear. So yeah. So these also contributes to the incidence of the pressure injury. So if your patient is lying on a bed, so just don't pull him like vigorously. Just always have your proper body mechanics and also your ways to turn a patient or position a patient. If you just pull him, he's already weak and he's very emaciated. So which again increases the chances of skin peeling for him. So never ever do like just pull a patient as such. And so now we are going through what are the areas of the pressure injury. So here we have the lateral position and the prone position also. So all these areas you can see if a patient is lying on a lateral position. So you can see his ears, his shoulders, his elbows, his hip, his knees, heel, and the ankle. So these all are the areas where there is a chance of the development of the pressure injury for the patient. And the prone position, if the patient is lying on the prone, because most of them doesn't like a prone position for a long time, but in case of any chances, like they want to be on the prone position because of the hemodynamical instability, some has to be on desaturated. So if the doctors, they wanted them to be on the prone position for the long time, because nowadays we are in the COVID status. So like for the maintain the saturations, our physicians, they wanted the patients to be on prone position, which there is a chance of increasing the saturation. So if your patient is lying prone for a long time, you just think your head, your elbow, your chin, your chest, the productive organs and the knees and the toes. These are all the high risk areas where there can be a development of the pressure injury. And sitting positions. If a patient is sitting there for a long time, maybe he may be a paraplegic and he can move his upper extremity, but his lower extremity he can't move. So, and he is sitting there for a long time in a wheelchair. Maybe there is no one else to take care of him. So if he's sitting for a long time, there is a chance for him to develop head, shoulder, sacrum, buttocks, and heel. And if it's in the supine position, because nowadays, like most of them prefers a supine position rather than the lateral or the prone or the sitting. So these are all the areas where they may develop a pressure injury on the later age. Initially, it may be a redness, mild red color, and then it increases to the darker red color. Then it becomes a skin peel. But if a skin peel happens, you know, like as we are going through the cases, if a skin peel happens and it's beyond the skin peel, something little deeper, it becomes very late to heal. Because you know, like because of the patient's comorbid status and also so many external factors, it's very difficult to heal also. And so we will be going now to the stage 1, stage 2, stage 3, stage 4, and other of the pressure injuries. So stage 1, what is the stage 1 pressure injury? There is nothing is there. You can see from the picture here, only redness. You can see only a redness. There is a non-blanchable redness. If you pinch for 5 to 10 seconds and if you leave off, still there. So it's a non-blanchable redness. So it's a stage 1. Some maybe will be a dilemma whether it's a stage 1 or plain redness, maybe a pressure injury beginning, or may not be. Maybe if he's lying there for a long time. So there will be a dilemma. So as the definition says, it's a non-blanchable erythema of the intact skin. You can justify the words intact, the skin is intact, but the redness may be there. It will not go off. Maybe it may go off. So we'll be in a dilemma whether it is stage 1 or a plain redness. So always take care of your patient's skin. And as I told you, it's an intact skin with a localized area of non-blanchable erythema. What is a stage 2? You can see from the picture. It's only a skin peel, but that's it, nothing more than that. Don't go beyond it. If a skin peel or a blister is there, that is stage 2. In stage 2, there will be a adipose tissue or the deeper tissues may not be visible, and the granulation tissue, slough or the scar may not be present. It's only a skin peel, but that's it, nothing more than that. A skin peel with a blister. If the blister is there, it can also be a stage 2. We can tell maybe the blister is there because it's very hot for the patient's body, but actually, as the guideline says, it's a stage 2 pressure injury. So stage 3, what is stage 3? It is a full thickness loss of skin in which the adipose fat is visible in the ulcer, and the granulation tissue and epiboly and are often present. There may be a slough or an eschar may be visible, and undermining and tunneling may occur. And in those cases, your fascia, muscle, tendon, ligaments, cartilages may not be seen, because if these all are seen, then it goes to the stage 4. See, this is a stage 3. Yeah, this is a stage 3. You can see here, and in which the adipose tissue is visible. Epiboly. Epiboly is the same, that the outer edges will be like little more above the wound bed, and it will be dry. That is the epiboly. And stage 4. What is stage 4? It's a full thickness skin and the tissue loss with an exposed. You can see from there. Everything, it's something like a hole. You can see everything. You can see your fascia, muscle, tendons, ligament, cartilages, and bone. There can be a slough or eschar, and epiboly may be there. Undermining and tunneling may often occur in those patients. But in these cases, you can see it's very small. But if the undermining and tunneling is there, it's a very big wound. If you like go for undermining and tunneling, if you check, maybe something like 5 to 10 centimeters inside. So it says like it's very big thing. It's something like an iceberg. Like you can see only a small from the top, like, but beneath it's very big. So always take care of the undermining and tunneling in those cases. So what is unstageable? You can see from here. The wound bed is completely covered by the slough or eschar. You can see this one. So you're not sure whether this is which stage. So that's why it's called as unstageable. So in most of the cases, the blood supply will be less. So always go for a blood supply to check always with this patients, and so always to check for the other blood conditions like diabetes, hypertension. So everything should be taken care always, and also a proper positioning and also caring of the extremities. Everything is needed, mandatory for these cases. So what is a deep tissue injury? As you can see in this picture, it can also be like, we can tell it's like maybe stage 1 or stage 2. You can see, but the color is like a deep red, maroon, purple discoloration. That is what, as per the NPIAP guidelines, they changed the color code. Like before, it was red only. Now it is like deep red, maroon, purple discoloration. Just specify those words. Like, so there may be a blood-filled blister. So you will be confused whether this is a stage 1 or stage 2, but you can check the color. It's a deep red, maroon, purple color. So it's definitely a deep tissue injury. So which tells you, implies like it's little more deeper. So something like an iceberg, it's little more deeper. So you have to take care of it. So what is a medical device related pressure injury? It's something like you have a medical device fitted to the patient. If it is there for a long time, it cannot be removed, or it cannot be just taken off for a few seconds or few minutes. So he has a higher chance of developing a medical device related pressure injury, which is, these injuries can be prevented to a larger extent while taking care. If you are not taking care of it properly, definitely I'll tell you, like, it's going to be a major impact on the healthcare system. So always take care of your medical devices whenever you have any of, maybe it's a simple thing, maybe it's an oxygen tube. I can show you in the picture. Maybe it's a simple oxygen tube, maybe a simple NG tube, or simple tracheostomy or urinary catheter, or something else like a stocking something. But if something is there, you should always take care, because it's something external which can harm your patient if you're not checking your patient's skin for a longer time, because we may be busy with the other patients. Maybe it's, I know, like nowadays, like we don't have 1:1 ratio for all the units. So our staff patient ratio is also more. So we'll be busy. It's obvious, like we are busy all the time. but always just give 5 minutes or more, not more than 5 to 10 minutes for a single patient to always have a recheck of his skin all the time, so that his skin has been rechecked and we can just position him. Most of the cases they have the caregiver or someone we can help the assistant from other staff, nurses also, so that they can be changed. So minimal change, 5 to 10 minutes per patient per shift can save a lot of prevention of the pressure injuries nowadays. But like, time also matters, everything matters. So always allot small minutes of your time to a single patient. So here you can see what are the risk factors. The devices are often rigid, and you know the medical devices, and it is often rigid, elastic, and secure with the tried dressings like your NIV mask, face mask, and your oxygen, NG tube, everything. And the microclimate and the edema of the tissue creates more pressure, and inappropriate size and the selection of your products. And these device related are more difficult to treat because these devices cannot be always removed or moved. As I told you, like, because the hemodynamical instability of the patient also has to be checked. Like if the patient is continuously desaturating and his vitals, everything is dropping out, I can't remove the NIV, or I can't take out the ventilation for him, because ventilation is priority and his hemodynamical instability is priority. But whenever he is stabilizing, we can take this NIV mask or something for a few seconds, like maybe I can tell you like 30 seconds, something like if he's not desaturating, then you can put it back. So all the time, just take care of your patient's skin, and the skin and the medical device should not be in direct contact. There should be some barrier device between both of them. And you can see here mucosal membrane. The mucosal membrane pressure injury is found on the mucous membrane with a history of medical device in use at the location of the injury. Due to the anatomy of these tissues, the ulcers cannot be staged. So maybe we are not sure whether it is epidermis, whether it is a dermis, or it's a skin peel, we are not sure. So these cannot be staged, but still it's a pressure injury. You can see from the picture. And some of the examples of the medical device-related pressure injuries are the oxygen tubings, endotracheal tubings, and the bite blocks, and the NG tube or the orogastric tubing, urinary catheter, and the fecal containment devices, everything. So these are all the examples of it. So if I have a ET tube, what should I do? How can I take it? I can't remove it, but I can reposition it, right? I can rotate the ET tube daily. Most of the ICUs, like, they are always changing the ET tube 24 hours. Changing the position, not changing the ET tube, changing the position of the ET tube. And we should always check the length before securing it. And the securing device should not be that use a securement device that can be loose. Like if something adjustment can be made, always use that one. And the NG tube. And the thing we have to do is that visible injury of both the skin and the mucous membrane, because as I told you, it's an NG tube. So the mucous membrane and both the skin are visible to you. So always don't tie your NG tube here, always tie your NG tube on the sides of both the sides. And you should change to the soft feeding tube when it is able. And if the patient can tolerate his oral feeds, it's better you go for an oral feed. Don't try to push him on the NG feed. Like if it's nothing, we can't do it, and he's very much dehydrated and his oral intake is very poor, then only go for NG, then only go for PEG. Before that, only always starts with the oral feed. And securement to be made floating in the nails. As I told you, the nail, it should be floating. It should not be fixed here, and it should be fixed on both the sides with the tapings. Like it should not irritate the patient's skin. We have so many companies with the different brand materials, so that it can be fixed on both the sides. And move the tube when the head turns to the sides. So if the patient is lying on this side, just position the tube on this side, like opposite side. Just don't tear the pressing materials, because as I told you, the skin is very delicate. There is a high chance of skin peeling, because we had so many cases like suddenly maybe the patient, he doesn't want to hear, he just pull it off. So that skin peel can happen. So this is also, so always take care of it. So what is a genital medical device pressure injury? Use an indwelling catheter for urinary monitoring only, or prefer an intermittent catheter. Check the location of the tubing with each repositioning, and also have a leg strap rather than the plaster, which should be applied on the thighs of the patient. And always have a key notification of it. So these are the areas you can see from the picture. And these are the medical devices which we are commonly using. You can see first one is the NIV mask. So, and like most of due to the COVID conditions, and most of them have the respiratory distress nowadays. So we prefer an NIV mask in those cases because we can't intubate him, because intubation is not mandatory or not maybe clinically indicated. In those cases, we prefer for an NIV mask. So if the mask is used there for a long time, you can see from the first picture, he can have a skin peeling. Maybe it can go up to stage X, like so many cases we have seen. It can go up to stage X. So always have a secondary dressing between the NIV mask and the patient's skin. And the next one is a tracheostomy. And tracheostomy, you can see here, there is a redness around the stoma site. So always secure a device, secondary dressing over it. And this is a restraint. See if the patient is kept unnoticed for a long time with a restraint, he can develop this one. So this is also a demonstrated pressure injury. And the braces, you can see here from a braces unnoticed. And the rigid splints or traction, and the nasal cannulas, and the tubes and cannulas. So all of them can develop. So always better go for a secondary dressing between the patient and the medical devices. Excuse me, I can't. Screen. I think, can I? Yeah, just 1 second. I think my side has stopped now. Yeah. Yeah. Okay. So what are the best practices? Always choose the correct size of the medical device to fit the patient size. That is always your mask, whether your oxygen mask or the NIV mask, always have the proper size of it. Always cushion the skin with a device. That's what I told you. Patients with a medical device have a secondary dressing or a barrier device, something in between. So that it's not directly going and touching your patient's bony area, which can always have a pressure injury. So your hospital acquired pressure injury rate will be more. So don't go for it all the time. So remove the device or move the device, attach your skin on a daily basis. Like what we are recommending is like whenever it is like possible, like 2 to 4 hours or even minimal within a shift, you should always check. Don't tell that my patient is hemodynamically unstable, so I can't. Maybe in some cases, but in most of the cases, we can prevent pressure injury. So always watch for edema under devices. Confirm devices are not beneath the individuals. Avoid placement of devices over sites. Educate the staff on correct use of the devices and the prevention of the screen breakdown. So how we can prevent it? We can do a skin assessment and we can do a risk assessment. Skin assessment every shift, like every shift is mandatory that we should do it. And also it depends, like it's like if the patient has a second hourly positioning, so you can check the time also. Head to toe assessment, you can check for him. If there are he developed any redness or anything, if any medical devices are there. So always check it. And the risk assessment. And what is the tool most commonly we are using here is the Braden scale. And the Braden scale is a very good tool for assessing whether the patient is at risk for developing the pressure injury. We have so many scores like for the adult and all the pediatric population. And the adult population and pediatric populations, the Braden Q scale, we are monitoring it. So there is a certain a score limit for both of the age limits, and which has got the intervention criteria also, and how frequent you should check it, how frequent you should do a Braden scale for a patient. It all depends upon the score of the patient. And ensuring the mobility to relieve the pressure and promote circulation. You minimize the pressure, like always minimize the pressure. That is offload. Offloading is one of the best things to reduce the pressure injury occurrence. So provide the adequate nutrition, which is very mandatory for all the emaciated patient, elderly bedridden patient. If the patient is adequately hydrated and nutrition, so it's always go for a dietitian referral or the nutrition consultation, anything for him. And minimize the friction and shear. Don't just abruptly pull your patient. Just always take care, do your proper body mechanics and a good positioning technique for him. Manage incontinence and moisture. provide patient, family, and caregivers education, which we think is a very good thing, because not only we'll be there with the patient for the 24/7. So always the family and the caregivers, because most of the family members, they are not with the patient. So caregivers are there. Maybe the caregivers, they will feel like little tired, because taking care of one single patient for a long time, 1 year, 2 year, maybe they'll be stressed or like they'll be tired. But just educate the caregivers how it can be done in a very simple manner. Maybe it will not take a lot of time for the caregivers, but if they know something about how they can position and how they can prevent, maybe the caregivers may not be well educated, they will not know, they will not be aware of the things. Maybe they will think it's just a simple redness, okay, no issues, tomorrow it will go off, tomorrow it will go off. So but if they're thinking like that for a long time, it suddenly develops into, you believe me, like we have seen so much cases, like they have the caregivers but they are not aware, like it's a pressure injury, because they are telling simple redness, maybe mama sleeping on the same side for a long time, redness is it, but it wasn't pressure injury, it developed into stage 3. So that's what we're telling, always give proper education to the caregiver. Just don't tell them position second hourly, position second hourly. Just tell them what happens if you're not positioning and what it can develop to also. So implementation measures, perform a head-to-toe assessment. If the patient comes to your unit, that is, it can be an ED, OT, ACU, daily, or on transfer or discharge using a facility-approved skin assessment tool. Always have a skin assessment tool for your facility. And it should always be done if the patient transfers from one department to another on a daily basis. And as per the score criteria, Brad score criteria, you should always do a skin assessment. You must repeat it regularly to determine any changes in the skin condition. For patients with limited mobility, use a pressure redistribution device. Just don't put the same patients like who has a high risk of developing a pressure injury on normal mattress, normal hospital mattress. Always have a special mattress on the top of it. What we prefer is an air mattress, because as I told you, gel mattress always like outdated. Like we prefer an air mattress. And if the patient in the home care setting also, we prefer the elderly bedridden patients or younger quadriplegic, paraplegic patients to be on a special mattress. That is like mandatory. They should not lie on a plain mattress or on a hot mattress. And they should always have appropriate skin cleaner and the bathing supplies, a lotion and the moisturizer. And the heel protection devices. Heel protection devices always should be there, because heels, they are the sides, heel, sacrum, trochanter, occiput, shoulder, elbow, all of the sides are the common sides of developing a pressure injury, because they may be lying there for a long time. Maybe their relatives, they are thinking patient is sleeping. The one is sleeping, my mama, my daddy, he's sleeping. So let him sleep for a long time. I should not disturb him. But just a little, maybe it doesn't take a long time, maybe 1 minute, not more than that. Just turn them a little so that pressure is relieved from them, so that there is a chance of developing the pressure injury reduces for him. And turn and reposition the patient regularly and frequently unless contraindicated. If it's really contraindicated, if the physician is telling don't ever turn your position, because he's very, very vulnerable to the change in the hemodynamic status. So you can just avoid positioning, repositioning for a small period of time. After that, we have to reassess if its condition is better. Just don't leave him, as the doctor told, like it's not good to change the position, just don't leave him. Recheck his condition. If after some time he's okay, it's good, his vitals all picked up, so you can just position him little. If he's still again not in hemodynamical instability, we'll just document and we'll continue with our care, and like we'll just try to modify our care. So these are the devices, as I told you, the air mattress, the heel protectors, and your moisturizer lotions. So there are a few things which contributes to this one also is the management of the pressure injuries, the pressure offloading, education. Education is one of the main important thing. We may think it's very simple thing, but just believe us, like education to the patient and also to the relative and also the caregiver is a very important thing. You should always education, also reinforce them, like how we can do it, how we can manage it. And antibiotics and medication, advanced wound care, relief, redistribution, nutrition. So all of these factors will contribute to the reduction in the rate of the pressure injury. So there are some of the complications of pressure injury, which are like infection, pain, osteomyelitis, social isolation, and sepsis. So like we have seen cases also like the patient, this simple pressure injury, he comes to the unit and then he goes back, then he develops a bigger thing, and then he comes back as sepsis, and then he dies also. So just don't, it's not good, or it's not like good to hear like someone who dies of sepsis because of the simple thing which can be prevented. So always take care. Prevention is better than cure, which I told you. And this is what we call as a skin bundle.
Miss Maya, we can't
Yeah,
hear you.
you can't hear me now?
Now it's fine. Yes.
It's okay?
Yes.
Yeah, okay. So as I told you, like we have a skin bundle in the surface. Make sure your patient have the right support. Skin inspection. Every inspection means early detection. Show patients and carrier how to look for, how you should inspect the patient's skin. And you always keep your patient moving. And the I stands for incontinence moisture. That is, your patients need to be clean and dry. And the nutrition or hydration. Help the patient have the right diet and plenty of fluids. And so these are the reference from me, NPIP guidelines, Braden's and CDC guideline, JCI, Accreditation Center for Medicines and all. So as I told you, there are some small things which can be prevented. So always prevent it better than going for the treatment and the advanced treatment. Just try to prevent it so that we can save a lot of time and a lot of energy. So thanks a lot for everyone for your patient listening. Is there anything, any questions or anything I can do for you?
Thank you very much, Ms. Maya, for that wonderful presentation. I'm sure our attending audience have a few questions, but we will be taking them by the end of the session. Thank you very much. Our next speaker for tonight, who will be speaking about the critical care nutritional management, will be Ms. Afra bin Katta, the president of the Emirates Clinical Nutrition Society and specialist clinical dietitian, head of nutrition department in Dubai Hospital. Thank you very much for joining us, Ms. Afra. The floor is all yours.
Okay.
You can just put it on screen, a full screen mode. We can see your presentation.
I'm trying to do it. Okay, you can see now.
Yes, you can go ahead. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I want to see. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. It's my pleasure to welcome all attendees and special thank for our speaker, Dr. Ashraf and Ms. Sumia. Today, I'm going to talk about the medical nutrition therapy in critical care. Critical care are defined as the complex medical management of seriously ill or injured person. This level of illness or injury involves acute impairment of one or more vital organ system with a high probability of life-threatening deterioration of the patient condition. Critical ill and injury result is profound metabolic stress and alteration, beginning at the time of the injury and persisting until wound healing and recovery are complete. And the metabolic stress is associated with an altered hormone state that result in an increased flow or mobilization of substrate, but poor utilization of glucose, protein, fat, and oxygen. Stress coming from sepsis, trauma, burn, psychological stress, exercise, pain, hypovolemia, hypoglycemia severe electrolyte disorder. Nutrition support in critical illness. As you know, the nutrition role has now come to be recognized as sine qua non in management of critically ill. So, providing nutrition via a functional digestive system is the preferred route of feeding rather than parenteral feeding. And those particular care should be taken to evaluate if the patient can tolerate enteral feeding. On the basis of the nutrition assessment, the expected duration of nutrition support and appropriate route of delivery, whether enteral and parenteral, a nutrition plan is formulated to meet the patient nutritional needs. Nutrition support therapy or nutrition rule therapy incorporate early enteral nutrition when visible. Appropriate macro and micronutrient delivery and glycemic control. Consideration of enteral nutrition being as follows. First, after stabilization of vital function as hemodynamic, volume status, or respiration. Second, after resistation, after assessment, after planning, after confirming the position of tube, as well as within 12, it is important, within 12 to 24 hours of an acute event, whether operation or trauma. And the benefit of early enteral feeding is reduce inflammatory response to stress, prevent mucosal atrophy, loss of gut barrier, liminal delivery maintains GALT and MLAT, systemic immunosupport, help maintain normal gut bacterial growth, less insulin resistance as hyperglycemia more common, portal nutrient delivery allow for first pass effect, more balanced nutrient delivery possible. As well, we need to understand the pathophysiology of the critical cases. It has gained importance with the better understanding of the pathophysiological of protein energy malnutrition in intensive care unit patients and optimal modality in administration of nutritional therapy. Its state has changed from being adult in critical care to that of definitive therapy. Pre-existing and ongoing protein energy malnutrition is a common problem in the hospitalized patient, but its state is often difficult to accurately estimate, partly due to increased catabolism, anorexia, the depression, gastrointestinal symptoms, therapeutic restriction, medical and surgical factors contributed to aggravation of malnutrition. In the end, the protein energy malnourish causes and associated with the muscle weakness, increased risk of infections, impaired wound healing, and prolonged time to convalescence. Nutrition care objective of critical care is minimize of starvation, prevention or correction of specific nutrient deficiencies, malnutrition or inflammatory response is present. The nutrition diagnosis should be framed around these conditions, provision of adequate calories to meet energy needs while minimizing associated metabolic complication. Fluid and electrolyte management to maintain adequate urine output and normal hemostasis. Currently, focus more on attenuating the metabolic response to stress, preventing oxidative cellular injury, and modality the immunoresponse. As we have as we have indicated, the importance of a more accurate nutrition assessment, the traditional method of assessing nutritional status are often of limited value in the ICU setting. The severely injured patient is usually unable to provide dietary history. Values for weight may be erased after fluid resuscitation, and anthropometric measures are not easily attainable, nor are they sensitive to the acute changes. The research studies found no equation currently predict REE اللي هي resting energy expenditure is most hospitalized patient without a reliable predict equation. Only indirect calorimeter will provide accurate assessment of energy need. Also, indirect calorimetry is considered the standard of assessing rest energy expenditure in the hospitalized patient. The study also found that even the most accurate equation, اللي هي Hurst and Bendix, was inaccurate in 39% of the patient and had unacceptable high error, without knowing which patient rest energy expenditure being accurately predicted. Indirect calorimetry may still be necessary in difficult to manage hospitalized patient. However, in the end, several predictive equations are commonly used in practice, as well as when designing and monitoring the nutrition prescription for critically ill patient. Focus should be on laboratory data, not in defining or determining nutrition status, because that the patient is so ill. Orally intake of food or fluid may be severely limited. As example, hypoalbuminemia reflected severe illness, injury, and inflammation. Those serum albumin should not be used as a marker on nutritional status. Other plasma proteins such as prealbumin and transferrin often drop prescriptively related not to nutrition status, but to an inflammation, induced decrease in hepatic synthesis, and changed causes by compartmental shifts in body weight. Nutritional medical nutrition therapy in critical is the important part for us. We know the key to successful nutrition management of critical patient is in start with the proper nutrition assessment, then diagnosis, finally intervention and monitoring it. So providing macronutrient to include the full range of elements and vitamins is integral part of nutritional support as started in the ISPN guidelines. And this is the present guideline is an update and extension of the previous ISPN guideline on enteral and parenteral nutrition in adult critical ill patients published in 2006 and 2009 respectively. Some elements and vitamins have numerous functions that they generally exert in combination. They are essential for the metabolism of carbohydrate, protein, lipids, for immunity and antioxidant defense, also wound healing. The present recommendations are limited and focus on the sum of the elements were studied. Wound healing management with critical cases. In the studies, increased needed for energy protein not less than 1.2 gram per kilogram from the ideal body weight or adjusted body weight for the obese patient. As well, zinc, vitamin A, C, and E have been documented. As the studies manifest, high-protein oral nutritional supplements are effective in reducing the incidence of pressure ulcer in patients at risk. So the energy, protein, arginine, and micronutrient, vitamin A, C, and zinc are all vital in wound healing. Wherefore, a lot of micronutrients have antioxidant properties, promote collagen synthesis, and augmenting to the immune system response. In ischemic tissues, within pressure ulcer, large quantities of free radical are formed. So the micronutrients such as the selenium and vitamin A, C, E may deactivate free radical and potentially accelerated wound healing as per study. Arginine and scientific facts. Arginine is synthesized in the healthy human, but additional arginine is needed for the young growth animals and after injury. The role of arginine in relationship with the wound healing: first, high reactive nitric oxide is generated from arginine by nitric oxide synthesis. Second, nitric oxide has many biological effects related to regulation of vascular tone and blood flow and those hypertension and atherosclerosis diseases. Administration of arginine improves blood flow to limbs of both healthy and diseased individuals. Another important finding is that arginine stimulates the release of growth hormone as well as insulin-like growth factors, both of which can improve wound healing. Augmentin, also derived from the arginine, can promote vasodilation and lower blood pressure. As well, and the role of arginine with infection. Both studies mention it is the harm used when the arginine alone was given to septic patients, because any effect of arginine supplement during the sepsis are most likely related to generation of nitric oxide and its effects on the cardiovascular function, including reduction in systemic blood pressure. However, other mechanisms could be improved, including an increase in microbial growth rate. The best dose of arginine supplement appeared to be about 2% from energy, around or approximate less than 10 grams daily given orally to adults is well tolerated and safe. Omega-3 acid and wound healing. McDaniel study showed that the effect of fish oil administration compared to the mineral oil in the healthy adult, the group whom received the omega-3 supplement have greater epithelialization of the plaster than did the control group, clearly suggesting improved wound healing. And other studies showed that the effect of omega-3 on infection, the conclusion was that omega-3 acid will favorably influence cytokine profiles to an anti-inflammatory state and had a significant inverse relationship with mortality, reduced mortality and infection rate, and length of the stay when administered in infusion dose between 0.1 to 0.2 gram per kilogram per day. Omega-3 fatty acid dose is approximately 3.5% of energy. This dose of omega-3 appear to have a relatively strong effect in reducing wound infections. Vitamin A stimulates epithelialization and the immune system response, promote aggregation of the monocytes and macrophages, increase the number of macrophages and microcytes in the wound, support mucosal and epithelial services, increase collagen formation. Dosing for pressure ulcer management in all stages are 10 to 50,000 international units per day orally for injured or severely malnourished patients, and maximum dose is 25 to 50 international units for 10 to 40 days. Deficiency may lead to alterated immune function, impaired collagen deposition, and delay wound healing. Vitamin C increase iron absorption, increase resistance to infection by promote migration of white blood cells to the wound, as well as promote fibroblast activity. Vitamin C is the cofactor for hydroxylation of proline or lysine in the process of collagen formation. The dosing of pressure ulcer management in stage 1 and 2 ulcer is 100 to 200 milligrams per day, and stage 2 and till to stage 4 ulcers is 1,000 to 2,000 milligrams per day. In patients with the renal failure, the dose is adjusted to 60 to 100 milligrams per day to diminish the risk of stone formation. And the deficiencies lead to impaired fibroblast activity and consequently impaired collagen synthesis. Moreover, deficiency decreases the capacity of the fight infections by impairing the immune system function. Zinc is an essential element required for cell replication and growth and protein synthesis. In management of the patient with any stage of pressure ulcer and zinc deficiencies, the recommendation dose for the zinc supplement is 220 milligrams per day for 10 to 40 days. Fluid. Adequate fluid intake is necessary to support the blood flow to wounded tissues and to prevent the additional breakdown of skin. The National Institution of the Health and Care Excellence 2006 recommendation 30 to 35 ml per kilogram from body weight fluid, and currently recommendation from the ASPEN for water intake are 30 ml of the body weight or 1 to 1.5 per calories expended. And for the healing of pressure ulcer, 30 to 40 ml per kilogram or 1,500 ml per day is recommended. And taking into consideration the patient with the pressure ulcer may have additional fluid required since the fluid may be lost via wound exuded. Fluid replacement depends on the volume of losses experienced by the patient, like draining wound, fever, and gastrointestinal losses. The patient comorbid conditions such as the renal or cardiac diseases. Summary: poor nutritional status are at admission and adequate nutrient intake during the hospitalization contributed to decline. For the nature of nutrition recommendations and intervention have changed and improved as per guidelines, with decreased length of stay in acute care setting. So just advise the dietitian to adapting and follow the optimal methods for the identification and under nutrition in hospitalized critical cases. with some of modifying if needed. Thank you for your listening. And if you have any question.
Thank you very much, Ms. Afra, for that wonderful presentation. We will be moving on to our next and final speaker for tonight. We'll be speaking about the nutrition and wound healing, enhanced recovery after surgery. Dr. Ashraf Al-Houbi, consultant of and head of the ICU department, chairman, Infection Control Committee in Dubai Hospital, as well as the examiner of the Royal College of Physicians in the United Kingdom. Thank you very much for joining us, Dr. Ashraf. You can go ahead and share your presentation. The floor is all yours.
Thank you very much, Alia, for the introduction. And I'd like to apologize to our audience as some technical glitch did happen before. I assume that my computer was attacked by a virus or something. I hope it is not COVID, because I managed to cure it in 10 minutes. You know, COVID takes a longer time to heal and to cure. I will be spending the next 25 minutes talking to you about the importance of nutrition, not only in wound healing, but in the process of recovery in general, particularly after surgery. That's the concept which has been going on for the last decade. We call it the enhanced recovery after surgery. It is a protocol which helps the patient to recover fast after surgery. And to our surprise, that this protocol was an association of a combination of evidence-based perioperative strategies. When you implement them all together synergistically, they speed the recovery after surgery. And for our luck, you can see it's a multimodal intervention. There is something like 25 interventions need to be done if you want to enhance the recovery after surgery. But today, we will be only focusing on the nutritional role in enhancing the recovery after surgery. Now, why nutrition and surgery are related to each other? Actually, there is a complementary relationship between nutrition and surgery. To start with, a surgical patient is at high risk of nutritional depletion, simply because of the stress of surgery and the disease impact. And the higher the stress of the disease, the more likely that the patient might suffer from nutritional depletion. On the other hand, if the patient was malnourished or undernutrition is there, the incidence of post-operative complications will significantly increase in the delayed wound healing, infection complications, and increased length of stay. So let's talk a little about the ERAS protocol from the nutritional point of view. We will only focus about how nutrition can be used to enhance recovery after surgery. And the first point in the preoperative period is the preoperative nutrition assessment. Why preoperative nutrition assessment is important? Because preoperative nutrition assessment, which usually and oftenly missed, you find that most of the surgeons will send their patient to a preoperative anesthesia clinic, but we seldom see them sending to a nutrition clinic. So they don't think that nutrition is important, which is very serious. Now, it's essential to identify preoperatively by proper nutrition assessment who is malnourished, because as we mentioned before, a malnourished person is likely to have post-operative complication, including delayed wound healing. And to identify also those who are well-nourished, but at risk of develop malnutrition or undernutrition during the process of surgery. What is the importance of that? It will allow us to provide what we call nutrition, which is goal-directed. This means if I'm anticipating that this patient who is actually not malnourished now, he might be undernourished because of the stress of surgery and prolonged period after surgery, then we should start the nutritional support preoperatively. And this is what we mean by goal-directed therapy as a preoperative nutrition. Is that important? Yes, look at the red boxes. People who are either malnourished or at risk of undernutrition are having an increased complications, whether this complication is infection complication or non-infection complications, 17 to 7%, 14 to 5%, in addition to increased length of stay inside the hospital. The problem with the preoperative nutrition assessment that if you ask a surgeon, do you think the nutritional status is important in the post-operative course of the patient? He will say yes. Do you think it is important to send the patient for a preoperative nutrition assessment? He will say yes, but only minimum of them, less than 20%, who will pay an attention and make a preoperative nutrition assessment to detect who is malnourished and who is under at risk. You can use any form of nutritional screening, whether it is the NRS or the Nutric score. And once you identify people who are malnourished or at nutritional risk, you should start the preoperative nutritional therapy right away. The ESPEN guideline have clearly said in their 2017 version that if it is anticipated that the patient will be unable to eat for more than 5 days preoperatively, or he is unable to achieve 50% of the recommended oral intake for about 7 days, the preoperative nutrition therapy should start right away, either by ONS, which is the oral nutritional support, or by tube feeding without any delay. So it's very important to see that because it's written in all the guidelines. This is the ESPEN guideline, which said also clearly that moderately or severely malnourished patients scheduled for elective surgery must have early preoperative oral or enteral nutrition in order to improve the nutritional status, because this proved to improve the post-operative outcome. Some people say, why not to use parenteral nutrition? It's an easy. You bring the patient to the hospital and put him on parenteral nutrition for a short period, and you can give him whatever calorie and protein which you want. We have a rule. If the gut is functioning, use it, either orally by ONS, oral nutritional support, or by tube feeding. Parenteral nutrition can be used if you are not able to use the oral form or the enteral form. So always focus on early oral, early enteral, or delayed parenteral. But it's also important to know that the ESPEN guidelines in their 2016 version, they have said that if a high nutritional risk person, like the people who have a high NRS score or Nutric score, and enteral nutrition is not feasible, then start parenteral nutrition as soon as possible. So the rule is early oral, early enteral, delayed parenteral. But if the oral intake is not feasible and the patient is malnourished or at high risk, then use the parenteral as soon as possible. So this is the ERAS protocol from the nutrition. The second important point is to optimize the calorie and the protein intake, both at the preoperative and the postoperative period. And I think Afra already mentioned that is the gold standard. In order to know how much calorie you want to give to your patient, you have to use indirect calorimetry, because it calculates the oxygen consumption and the carbon dioxide production, and it will be able to tell you exactly the resting energy expenditure, to which we can add always a risk factor or a stress factor. Then we know how much we can give our patient. Unfortunately, despite it is mentioned in all the guidelines, ESPEN, Canadian, Spanish, any guideline is depending on indirect calorimetry, but it is not usually available in all hospitals, even in critical care units. Luckily, we started to have an alternative method using the mechanical ventilation by calculating the volume of carbon dioxide produced by the patient, multiplying it by a constant factor, which will give us the resting energy expenditure. Unfortunately, not all the ventilators are having that yet. So if we don't have the indirect calorimetry, what should we do? As Afra said, we will either use the predictive equation or we can use the simplistic weight-based equation. We know it is not accurate, but this is what we can do if the indirect calorimetry is not available. What about the protein? protein is extremely important because the patient who is under stress is degrading his own protein. And if you don't supply the patient with enough protein, the patient will start to have a severe muscle wasting. If you look at the upper part of this slide, you will notice that if you are under stress, whether it is due to surgery or infection or burn, you will increase the metabolic stress and you will increase the muscle degradation and protein loss as evidenced by the increased urea excretion in the urine. And the patient will have a severely negative nitrogen balance and will start to lose the muscle. If you look at the lower picture, you will notice that if the demand is high and the supply is low, there will be no no protein synthesis, and there will be a lots of muscle breakdown. And this is the picture we usually see in the intensive care unit in a neglected patient from the nutritional point of view, if you don't give the patient enough protein while they are in the hospital. You can read, you can lose as much as 1 kilogram of lean body mass daily because the patient is severely hypercatabolic while you are not giving him enough protein. So the patient is in high demand, but you are not meeting those demands. The next point in the nutritional protocol for ERAS, similar to optimizing the macronutrients, we need to optimize also the micronutrient. You have already heard from Afra and from Somia the importance of the micronutrients like vitamins, whether it is vitamin A, C, D, or the minerals like the zinc and selenium and iron, which we usually call some of them the trace elements. All of them are extremely important in preventing wound damage and in improving the wound healing. They are extremely important and need to be adjusted properly. Probably you heard what Afra said about the albumin. We don't usually use the albumin as a marker of nutrition. But what is the bigger problem is that the low albumin, regardless to its cause, will make a delayed wound healing. So the constant recommendation is don't let the albumin be low because good albumin is good for wound healing. So improve wound healing by improving the albumin, which is quite important. Similar to that is the glycemic control. We all know the drawbacks of bad blood sugar control on the skin. We have seen most of the pressure ulcers and the diabetic foot and all these stuff. They are very common in patients who have a poor glycemic control. So it is essential if the patient is coming for elective surgery that we make sure that their diabetes is under control, their hemoglobin HbA1c is less than 7, and we keep the blood sugar control at an optimum level. Is that important? Yes. Look at this. A high blood sugar, regardless to all of those mechanisms, will lead to impaired wound healing. So similar to improving the macronutrient, improving the calorie and protein, improving the micronutrients like the vitamins and trace element, controlling the serum albumin, controlling the blood sugar, it's extremely important to help the wound healing and to improve the recovery after surgery. The next one on our ERAS nutritional protocol is the immune nutrition. You have heard Afra talking about the immune enhancing nutrition, similar to the arginine, the glutamines, the omega fatty acids. We know that immunomodulating nutrition is important because patients who are going for dangerous surgeries, particularly cancer surgery or major abdominal surgery, it is documented that if you give them pre-operatively some 5 to 7 days of immune nutrition, the post-operative course becomes very favorable. That's why in the 2006 guidelines of ESPEN, they recommended as grade A recommendation that people going for cancer surgery and major abdominal cancer surgery will take those kind of immune enhancing nutrition. The ESPEN guideline, which is being produced with collaboration with the Society of Critical Care Medicine of North America, also considered the immune-enhancing nutrition in major cancer surgery, and that was in 2016. The ERAS Society have focused on this, and they make a meta-analysis, and they realize that this immune nutrition, if it is given for major surgery, particularly if it is cancer surgery, it has a 41% reduction in infection, and it also improved the length of stay. This means it enhanced the recovery of patients after surgery and cleared the hospital beds much faster. And that's why they give a standard recommendation from 2015 that in major surgery, particularly cancer surgery, you may need to give the patient immune-enhancing nutrition for 5 to 7 days. Do we need to give that to everybody since this immune nutrition is beneficial? The answer is no. Because in 2018 guideline coming from ESPEN, which is being just released a couple of years ago, said, yes, it is okay to give it to major cancer surgery, but there is no enough evidence to give it to critically ill patients. So restrict the immune nutrition for now for the major cancer surgery, whether it is head and neck or major abdominal surgery, because this proved to improve the recovery after surgery, improve the wound healing, and decrease the length of stay and decrease the infection complication. The next item in our protocol from the nutritional part on the ERAS is to decrease the preoperative fasting time. Now, this is very important because we know from our anesthesia colleague that they want to keep everybody fasting from midnight. And if the patient have taken anything orally, they cancel the surgery. We see that every day. Despite it is known long time ago, do you see the date? It's 1800s by Sir Joseph Lister. He is telling 2 hours before surgery, you can take clear liquids. Why you want to keep the people fasting for this long time? And that's why people used to do that from midnight, but the new evidence have said that there is no harm if the people going for elective surgery will take liquids, particularly clear liquids, up to 2 hours before going to the surgery. And that's why the European Society of Anesthesiology have said that clearly. You only need to take non-milk clear liquids up to 2 hours before elective surgery. You don't have to stay all night long fasting. And it is also, even the solid food, it is written up to 6 hours. So it looked like we used to starve our patients for up to 12 hours before surgery unnecessarily. It is documented now. This is the European Society of Anesthesiology, and this is the American Society of Anesthesiology. They are more accurate in saying fatty foods 8 hours, light meals 6 hours, clear liquids for our pulp-free juice up to 2 hours before surgery. And if you do that, you usually improve and enhance the recovery after surgery. Then there is no need to keep the people fasting for 12 hours before surgery because you are afraid that this might cause a post-operative complication. The last one is the carbon loading. Carbon loading is a new concept which we realized that if you give the patient a carbohydrate loading before surgery in the form of 400 or 800 ml of carbohydrate drinks, like 12.5% carbohydrate drinks, that improved the outcome after surgery. Why? Because it induced the insulin release and it decreased the insulin resistance. You see the benefit of the carbon loading, giving the patient a carbohydrate load just before the surgery by 2 hours. It reduced the metabolic stress. It reduced the insulin resistance. It improved the post-operative muscle function. And it reduced also the lean body mass loss. If you look at the red bars, this is how you lose your muscle mass. This is the insulin resistance. So if you give the patient a carbohydrate load up to 2 hours before surgery, oral drinks, not IV, that will decrease the insulin resistance by almost 50%. And look, in all kinds of surgery, cholecystectomy, colorectal surgery, arthroplasty, all the orthopedic surgery. This is also an evidence that if you give the preoperative carbon loading, that will increase the anabolism to the proteins of the muscles. The protein tyrosine kinase activity in the muscle is increased. This means the muscle synthesis is improved and the muscle loss is decreased. So if you give a preoperative carbon loading, the muscle mass loss is reduced. And as you can see, it is statistically significant. And that's why it is clearly written in the preoperative guidelines for the ERAS protocol that you need to give a carbon loading, carbohydrate-rich drinks orally up to 2 hours before elective surgery. And it is very beneficial because it improves the patient. The post-operative one is my last slide. And now I need only to warn you that those 4 surgeries, which is straightforward and uncomplicated. This means when I'm telling to you that post-operatively, the patient need to drink immediately and need to eat normally as early as possible, I'm talking here about a straightforward, uncomplicated surgery. We're not talking about a patient who has complications in the OT, which result in blood loss, and the patient became hypotensive, and the patient have multiple complications in the OT. Those patients will follow the protocol of critical illness nutrition, similar to what Afra told you. You have first to fully resuscitate the patient. You have first to keep the patient at optimum vital signs. You have to make sure that all the organs are well perfused, because if the organs are well perfused, then the gut is well perfused, then you can start the feeding. So what we are talking about early post-operative recommendation of immediate drink and eat normal and go to 1,000 to 1,500 calories per day. This is in uncomplicated, straightforward surgery. The patient will come out in a good shape, not the complicated one which resulted in a problem. And it's very apparent that the randomized controlled trial, which compared the early enteral or oral feeding compared to MPO, we see the surgeons asking us to keep the patient MPO forever. They want the patient to stay not eating forever. That's not good, because this is always delayed the wound healing. It increased the incidence of infection, and it increased the length of stay in the hospital. So it is very important to know that in an uncomplicated, straightforward surgery, early institution of oral feeding is essential. And look at this. Everything on the left side of the straight line is telling to you that it is good. And look at this, the first one, anastomosis dehiscence. Most of the surgeons are afraid when they make resection anastomosis, he tell you keep the patient MPO because I'm afraid that the anastomosis will leak. Actually, early nutrition help the anastomosis to heal, and it prevent anastomosis dehiscence. So early feeding improve anastomosis integrity, decrease the wound infection, at the site of infection and other infections, and actually it has a favorable effect on mortality. So if we look at the ERAS protocol, nutritional protocol, to enhance the recovery after surgery, you will find multiple points. All of them are evidence-based. All of them are proved to be beneficial, but the important one is to bundle them together. So if you implement them synergistically, this will enhance the recovery and improve the wound healing, because this is what we want. We want the patient to recover properly after surgery and leave the hospital early, fully functioning. That's my last slide, and thank you for very much for listening.
Thank you very much, Dr. Ashraf, for that wonderful and extensively informative presentation. And I would also like to thank all our guest speakers. If we can join together for the question and answers, I'd just like to remind our audience, if you have any questions, you can type them in the Q&A box in your panel, control panel down below. Okay, so if we're all here, we can move on with our first question. Okay, the first question, can DTI be considered as unstageable pressure injury I'm presuming this is for Ms. Somia. Can DTI be considered as unstageable pressure injury?
Can you hear me now?
Yes, yes, I can hear you.
No.
Okay. It is not considered as an unstageable.
Unstageable is something like there is a slough or an esca should be there. And DTA is something like there is a deep, as I told you in the definition, it's like a deep red mirror discoloration. It can blister maybe. So it's different.
Mhm.
When we go for the clinical practice, we can highly observe it. Both are different.
Okay, thank you for that. Okay, our next question. Do you use indirect calorimetry in the hospital, and which brand is available in the UAE to use in hospital patients? This question is, I think, for Ms. Afra. Indirect calorimetry.
Till date, actually, we don't have, but previously I have one. It was in one of the government hospital, but it unfortunately it not adapt with the ventilator. So we facing this is barrier with the so for that we didn't use. And today now we don't have.
Yeah, that's why I mentioned in my presentation, despite all the guidelines have mentioned that indirect calorimetry is the gold standard. But if you look at all the big hospitals in Dubai, you will hardly find one using an indirect calorimetry. We can use the indirectly, the volume of carbon dioxide evolved from a ventilated patient and multiply it by a constant factor of 8.9. That will give us an approximately the resting energy expenditure. But unfortunately, like what Afra said, we don't use indirect calorimetry.
True. Okay. Moving on, our next question from Dr. Abdulrazak. Electrolyte balance in critical care unit is important. Okay, I think he agrees with you, Ms. Afra. Next question would be, what would be the ideal biochemical indicator for a good nutritional status in a long-term care patient? For Ms. Afra, this question might be.
Chemical, what do you mean chemical?
What would be the ideal biochemical indicator for a good nutritional status?
I think he means the albumin, pre-albumin, transferrin, and
lab result. Which one?
Yep.
Indicator as lab result.
As a state of nutritional status for long-term care patients.
Yes. The other like pressure, glycemic, glucose, blood glucose, as well oxygen, blood oxygen. It's very important in with the critical care. And we can revise all as roughly we can revise all the lab results for the patient to take the image for evaluation.
Okay.
What is important here, Afra is trying to tell you that it doesn't mean that we said that inflammation decreased the albumin and pre-albumin and transferrin, that they are not important. They are. Because long-term care patients, they don't have high inflammatory status. So albumin and pre-albumin and transferrin will be good indicators. But you are using other things, arm circumference, skin fold, the muscle grip. You have lots of things. Ultrasound now is used to tell us exactly about the nutritional status and the muscle mass. And there is even in sarcopenia studies, you can use certain indicators using a CT scan to give you the fat-free muscle mass. There is a lots of things. Some of them are sophisticated, some of them are easy, but you can just look at your patient. You will know if he's malnourished.
Anthropometric.
Okay, what about the use of glutamine in wound healing? That is one of the other questions that we're having.
Yeah. I think I can answer that. We have a little problem with these immune-enhancing proteins and fatty acids. The primary problem that there was a high enthusiasm that the glutamine arginine from the protein side and the omega-3 fatty acid will be beneficial for everybody. So what happened is few trials is being conducted particularly between 2010 and 2020, using a high dose of glutamine and arginine, and unfortunately, it gave a bad outcome. And that's why everybody is backing out from using those immune modulating nutrition for everybody. And we should restrict ourselves to the guidelines. So the guidelines say the immune modulating nutrition containing glutamine, arginine, and omega-3 fatty acid to be given for certain patients only, like cancer patient, like cancer surgery, major abdominal surgery from cancer side, but not routinely for critically ill patients. If the patient is receiving parenteral nutrition for a long time, glutamine will be deficient because most of the parenteral nutrition does not have enough glutamine. Then you can supply that glutamine for those people, but those are minority of the patient who we have. Does glutamine help wound healing? Absolutely, yes. We know that. We know that. The problem is you have to implement this with the whole protocol to improve the wound healing and to enhance the recovery.
Yes.
Okay, thank you for that. In chronic renal failure patients with pressure ulcers, how much protein intake is considered as safe intake?
It should be not less than 1.2 and depend on glomerular filtration rate. We can calculate it for him.
Yeah, that's
our base. It is ideal body weight or adjust body weight for the patient.
It's very important for us to understand the difference between acute renal failure, chronic renal failure. Chronic renal failure on conservative management, chronic renal failure on dialysis. Now, if I have a chronic renal failure on conservative management, meaning he is passing a little urine, like a liter of urine with creatinine of 4 to 5, but he is not on dialysis yet, this one needs to have a restricted protein intake. That protein intake will be limited to his activity. But if that patient will go for dialysis, he will take like what Afra said, because dialysis remove a lot of protein from his body and it will make the patient malnourished. So you need to give the patient the high protein.
Yes, if it is impaired, we have to be restricted.
Yes, absolutely. Yes. In the acute renal failure, we have to understand that acute renal failure is not a disease. Acute renal failure results from another disease. So a patient who is septic, a patient who is hypovolemic, a patient who is polytrauma will develop acute renal failure. That patient is a critically ill patient. So he has to take the high protein even if he is having acute renal failure. And if you are not able to save the kidney, you have to start the patient on dialysis right away, not to restrict the protein, because the patient will utilize his own protein and will go into muscle wasting if you restrict the protein.
Okay, thank you for that. Does supplementation of vitamin D help in the healing of the patient? Vitamin D supplementation.
Vitamin D, I don't have studies. I didn't mention this is in my presentation, but there is another studies related to vitamin E, A, all of this for wound healing. But I don't have exactly studies for vitamin D.
We know that vitamin D particularly have some relationship with the level of calcium and calcium control, and it is effective in too many diseases, including renal failure, parathyroid illness, but to be used as a part of support or supplement for wound healing, it's not really.
We don't have.
Yeah.
Okay, Dr. Abdulrazak commented that post-operative fasting for MBM for 12 hours is ideal for post-op anesthesia complications, prevent aspirating pneumonia or vomiting or excessive calorie delivery complications. Please explain the diet in such conditions of EBB stage.
Okay, now we need to understand something. We have a saying, old habits die hard. Now, if you ask any anesthetist, he will tell you that you need to stay fasting without nil by mouth for 12 hours before surgery. Otherwise, your stomach content will make me a problem while I'm intubating you, so you may vomit and aspirate. Let me ask you, if I have to intubate a patient in ICU right now, am I asking him, when did you eat? I'm not asking him, when did you eat? Because I have to intubate him. So why we are not causing vomiting for those patients on immediate intubation without asking our patient in ICU to be fasting? So that's a myth. We now understand by the ERAS protocol that if you take liquids up to 2 hours before the elective surgery, it will not increase neither the intraoperative nor the postoperative vomiting. And if the patient is having a straightforward surgery, uncomplicated, immediately in the recovery room, they can start taking some clear liquids, and there is no evidence that this will increase the vomiting and the nausea and vomiting of those patients. What we are only telling you is avoid the heavy fatty food for at least like the Aspen guideline. The clear liquids is up to 2 hours. So this is the guidelines written by the Anesthesia Society and written by the ERAS Society. But as I told you, old habits die hard. There is always a resistance to change. Nobody is listening to the new evidence. And if a dietitian will tell that to the surgeon, he will never listen to it.
True. Okay, we have a question from Ms. Samia. What is the prevalence of the NG tube injury as the best way for a fragile or a badly injured patient who is extremely intolerant to the feeding?
What is NGT injury?
NG tube for Ms. Samia.
Yeah, can you repeat once again? I can't hear it.
The nasal injury. Okay,
Yeah.
okay.
The prevalence of the NG tube injury, and what is the best way for a fragile or a badly injured patient who is extremely intolerant to the NG tube?
You can go for a PEG tube.
Yes. Again?
We can go for a PEG tube.
We can go for a PEG tube. Okay. And what is the difference for kids, if there's any difference between that for children and adults?
Regarding PEG, NG feed or NG tube?
NG.
I think it's breaking in between.
The difference between kids and adults for NG tube.
It's the same, like who can't tolerate, who can't take by mouth, we are putting the NG tube. So it depends on those conditions only. We can't comment more than that.
Okay. Dr. Ashraf, if you could please share the research regarding the reduced preoperative fasting time.
I'm actually writing it for him. I already put in my presentation the European Society of Anesthesiology guidelines regarding the preoperative fasting time and the American Society of Anesthesiology, so the ESA and ASA. This is 2016 and this is 2017, and this is already based on hundreds of trials. The societies do not put guidelines based on expert opinion. The opinion about reducing the preoperative fasting time is already documented in both the European Society of Anesthesia and the American Society of Anesthesia and in the ERAS protocol. So if you want to Google it, write the preoperative fasting time, European Society of Anesthesia guideline, American Society of Anesthesia guideline, ERAS protocol. You will find all the indications and all the data written there.
Okay, thank you for that, doctor. Okay, how many days can we give TPN for ICU patients?
Okay, I can answer you that. Afra is with me in the hospital. She can enter the ICU. She will hardly see anybody on TPN. Why we do that? Because we like to use the enteral nutrition for all the patients. We only use parenteral nutrition when we are not able to use enteral nutrition. So if I have a patient with bowel gangrene, or I have a patient who is total bowel resection, or I have a patient who is having totally non-functioning, we can start TPN. So this is number one. In critically ill patients, we start enteral nutrition as early as possible within the first 24 hours. And we progressively increase both calories and protein over the next 3 to 5 to 7 days to reach the target. If we are not able to reach the target by day 7, we add what we call supplemental parenteral nutrition. This means an extra parenteral nutrition to support the calorie and the protein if you are not able to achieve. Then, for how long you can use the parenteral nutrition? For as long as it is needed. So if the patient goes for total bowel resection, indicated for parenteral nutrition, once his bowel started to recover, and we are able to give the patient some oral or enteral nutrition, like peptide-based or elemental or semi-elemental diet, once the patient can achieve the calorie and the protein, we can stop the TPN. But there is no duration called, I have to give it for a week or for we have a rule to start, a rule to progress, but when we stop, when the patient can take oral or enteral nutrition.
Okay. How much GRV NG feed should be hold, and for how much time in a malnourished oncology pediatric patient?
Okay, those are two different questions. You like to answer that, Afra? Are you still asking the nurses to measure the GRV? Now, the current guidelines for both aspirin and aspirin is telling the nurses do not measure the GRV. This is GRV is the gastric residual volume. We always test the tolerance of the GI tract to feeding by checking aspirating every 4 hours to see how much will come out of the tube. If you properly assess your patient before starting the feeding, and if you start your feeding gradually, this means you start trophic with 20 ml per hour, followed by 30, followed by 40, and then giving the patient a rest like between 4 to 6 hours and see exactly what will be coming back, you will probably be able not to do that. The new guidelines, particularly the Canadian, is allowing us to continue feeding if the GRV is up to 400 ml. Of course, 400 ml is too high. Once you find it, you have to start a prokinetic. A prokinetic means you can start either metoclopramide or erythromycin or some other antiemetics like the domperidone or the ornandosterols and all this stuff. But we do tolerate a higher GRV. Before it was 250 to 300, now it is up to 400. We must not stop feeding because feeding is extremely important and beneficial to the patient.
Okay, thank you for that. We will take one more question. We have a lot of questions, but we don't have much time. If a patient is in hepatic encephalopathy and his ammonia level is high, how much protein can be given to that patient?
Now, that's a difficult question. Go ahead, Rafra, go ahead.
Yeah, as per guideline for hepatic, it should be started from 0.2. We are restricted with him. 0.6.
Yeah. Now, you have to remember something which is very important. There is a difference between acute hepatic failure and chronic hepatic insufficiency.
I mean acute.
Yeah. So in the fulminant liver failure, where the patient is already in acute hepatic insufficiency, the restricting protein is important because sometimes a higher protein might increase the encephalopathy. But remember, the encephalopathy of hepatic failure patient is happening because of his gut content, not because of the protein content. That's why we give this patient cleansing enema. We give them some locally acting antibiotics, but the protein is not the problem. And remember, acute hepatic failure is an acute hypercatabolic state. So you have to make sure the urea nitrogen excretion and measure the nitrogen balance. Otherwise, your acute hepatic failure patient will go into dangerous muscle wasting if you don't give them enough nutrition.
Okay. Thank you very much, Dr. Ashraf. Thank you very much, Ms. Afra, Ms. Samia. It has been a very informative and wonderful talk. We have a lot more questions, but I'm sure we can't address all the questions. You're running out of time. So if you don't mind, we will be moving on with Ms. Jinan Assami from Abbott. who will be talking about nutrition for healing and recovery. Ms. Jinan Assami is the Associate Product Manager from Abbott Nutrition in the United Arab Emirates. Thank you very much, Ms. Jinan, for bearing with us. It has been a very long session. The floor is all yours, and you can start. Thank you.
Thank you for the introduction, Ms. Alia. I'll share my screen. Please let me know if you can see it. Can you see the screen?
Yes, very much. Yes, you can start.
Great. So first of all, I'd like to thank all the speakers for their very informative presentations. I know we're coming towards the end of our webinar, so I won't be taking too much of your time. Just wanted to quickly go over one of our latest additions to the Ensure portfolio, which is Ensure Plus Advance. Now, I'm sure many of you are familiar with Ensure. It's not a new brand for healthcare providers. It's a very well-established brand launched back in 1973. And over the years, it's grown and become, varied in the different types of products that we have in the Ensure brand portfolio, designed to meet the needs of specific patients, and of course, all having clinical studies to support them for malnourished patients, wound healing patients, patients with fractures, oncology patients, different types of medical conditions to meet the needs of whatever patient you are seeing in your hospitals. Now, Ensure as a brand is the #1 oral nutrition supplement worldwide. It's available in more than 85 countries. And as I mentioned, for the past 45 years, we've done more than 30 clinical studies on different types of Ensure products in the portfolio. So I know many of you are familiar with Ensure. We also have Ensure Plus. And today I just want to quickly go over to the latest edition, which is Ensure Plus Advance. We have 2 different types of packaging for this formula. Just recently, we've added the RPB, which you can see here on the bottom right-hand side. This is a reclosable plastic bottle, which can be used as a both oral and tube feeding supplement or enteral feeding supplement. And of course, we have the Ensure Plus Advance RTH or ready to hang, which is for enteral feeding patients. Now, what I really want to focus on are the 3 key ingredients that make Ensure Plus Advance different or unique comparing to the other Ensure products that we have in the portfolio. And what we have done is we've increased the protein content in this product, we've increased the vitamin D, and we've added a very unique ingredient which Abbott has the patent for, which is HMB, hydroxymethyl butyrate. Now, together, the combination of increased protein, vitamin D with HMB, along with the high calories, is a very unique blend of ingredients. And I think a one-of-a-kind formula in the market for patients that are suffering from low lean body mass, perioperative patients, as we discussed, also patients who might have any sort of wounds and require higher protein as well as HMB to prevent muscle breakdown. So if we look here at the breakdown or the analysis of the products, as you can see, it's a high calorie formula, 1.5 calorie per ml. It's a high protein formula. So in each serving of the RPB bottle or the reclosable plastic bottle, you have 20 grams of protein. And in the RTH or the ready to hang, you have 40 grams of protein. So if you're giving a patient 1 liter of the product, he will be getting 80 grams of high quality protein. And this is, as I mentioned, to support the protein needs for patients who might have any sort of illness, trauma, induced stress, and require higher amounts of protein. We have 1.5 grams of calcium per serving, whether it's in the bottle or in the RTH or the ready to hang. And the recommended amount in order to meet the needs of the patients is to have 3 grams of HMB per day. And so by giving the patient 2 servings of Ensure Plus Advance, you will be meeting the needs of HMB in order to help prevent muscle breakdown. For vitamin D, it contains 500 international units. So again, giving them 2 servings will be 1,000 units, which is the recommended amount. It contains fructooligosaccharides, or FOS, which is a prebiotic fiber that helps support the GI health of these patients. And it contains a full range, or 27 different types of vitamins and minerals to support the immune system. So just to give you a perspective on why oral nutrition supplements are very important, as you know, when a patient needs tube feeding products or enteral nutrition, there's no discussion with that. The dietitian, the physician is involved, the patient is giving the supplement. I think the challenge or the discussion comes around patients who can consume food. There's always a misconception that they can consume the full hospital tray that's coming to them, or at home once they're being discharged, that they can meet their protein needs. And we always want to just make sure that when you're giving the patient any type of supplement, it's really to help make it easier for them to meet their needs. So when we see here 2 bottles of Intra Plus Advance is about 40 grams of protein, that's equivalent to 6 eggs, or 1.25 liters of milk, or 200 grams of red meat, which might not seem like a lot of food to people who are healthy, but people who are hospitalized or have any type of medical conditions with their reduced appetite, it could be a challenge to meet their protein needs. Now, when we look at HMB now is really extensively studied. It's published in a lot of clinical trials, and it's also available in one of our other products that we have, and that's very popular in the hospital setting, which is Abound. And this product is used specifically for wound healing patients. So Ensure Plus Advance is the second product that we've launched with this unique HMB ingredient. Again, HMB is very difficult to get from the diet alone. You'd have to consume an unreasonable and unlogical amount of eggs or avocados or asparagus in order to get the recommended amount of HMB. And that's because very little of it is converted or metabolized from leucine. So about 0.5 to 5% of leucine is converted to HMB. And that's why when it comes to HMB, it's really important to give this ingredient in the form of a supplement. HMB, as we mentioned earlier, is proven clinically to combat muscle loss and to support the prevention or to prevent the breakdown of lean body mass in hospitalized patients. So for the sake of time, I won't be going through any of the studies that we have on Intra Plus Advance, but they are numerous studies which show that using Intra Plus Advance, you have better nutritional status, improved hand grip strength, increased strength and quality of life. We have studies for hip fracture patients and for rehab patients. Maybe later on, if anybody's interested, you can contact me by email, and I can share these studies with you, or our medical reps can also discuss these studies with you in any future visits. Okay. With that, that concludes my presentation. I don't know if anybody has any questions.
Thank you very much, Ms. Jinan. If we have any questions for her, we can take 5 minutes for that. Otherwise, like you mentioned, if we have any more questions, we can be happy to answer them by sending them to the email address that we have. Okay, yes, I think, Ms. Jinan, we have a question here. Is it high in electrolytes?
So I wouldn't say it's high on electrolytes. It depends which ones specifically you're referring to, but it's usually within the normal recommended amount, or the daily recommended intake for patients. So if there's a specific electrolyte that she's asking about, I can answer for that one.
Okay, okay, we've got a lot of questions here. Okay, let me see. Abound can be given for the chronic renal patient who is not undergoing hemodialysis. I'm not sure if that's a question or.
Abound, asking about Abound?
Yes, for
Abound,
chronic renal patients.
yeah, Abound is safe to be given to renal patients, even if they're undergoing dialysis, it's still safe for them.
Okay. Can this product be given via jejunostomy feeding?
Yeah, so this product can be given through, as I mentioned, oral nutrition supplement and any sort of enteral feeding. It's suitable for it.
Okay. Potassium and phosphorus. Maybe they're asking about the content of potassium and phosphorus.
Per 100 ml for Intra Plus Advanced, we have 100 milligrams of phosphorus and 235 milligrams of potassium. This is per 100 ml.
Okay, and there are a few questions regarding the prices of the product. If you can just give us a vague idea or a range.
So actually the price varies from hospital to hospital. I can't give a specific price about that. I would just recommend them to contact their medical rep who visits them, and they will have the most updated price. I don't want to be giving a wrong price and generalize it to everybody.
Okay, what is the osmolarity of the product?
The osmolarity or the osmolality?
Osmolarity with an R.
With the osmolarity, I don't have it at the moment, but for the osmolality, it's 501. Give me 1 minute, I'll get the osmolarity for you. In the meantime, is there any other questions?
We've got a lot of questions. I'm just trying to go by one. Can you explain more about the HMB detailed research?
Sure. Okay, before I move on, I just have the osmolarity is 557 milliosmoles per liter. Okay, so the HMB research, we have numerous research. I don't think I can actually go into details now, but I would love to get the contact information of the HCP who's asking this question, and we can discuss this in more details. But just, the main idea behind HMB is that it's what's being added now as a new ingredient to our formulas. It's a patent for Abbott, so only Abbott formulas will have HMB. Previously, it was available in a lot of sports supplements, so a lot of the gym users were using HMB, and that was to preserve their muscle mass. And now with the clinical studies and the research that's being done, it's also been proven to be effective in preserving the lean body mass of elderly patients. We have a lot of studies on patients that are discharged from the hospital, patients who have pneumonia. So there's a lot of different clinical conditions that we have the studies on. And I think if I can just get the contact details, or if they can email me, I'll be able to help them in more detail.
Okay, because that was one of the questions, if they would like to go for the discussion as well. Okay, what is the best way to administer Abound in NGT patient, NGT feed patient? How long can Abound stay in the hanging bag?
So Abound, as I mentioned, it can be given in any route in terms of enteral feeding. That's fine. With all our products, they can be safely hung for 24 hours.
Okay, and is it safe to mix Abound with another product?
We recommend to give each product separately.
Okay, HMB allowed in acute renal failure, CRF, hepatic coma patients.
So for renal patients, we have a specific formula, which is Nepro-LP and Nepro-HP. We don't recommend giving Intra Plus Advanced to renal patients unless the dietitian or the physician has a specific goal or is monitoring the patient very carefully. But from our side, any renal patient, as long as it's pre-dialysis, should be consuming Nepro-LP, and during dialysis, consume Nepro-HP.
Does Abbott have a continuous feeding pump? It's an off topic.
Yes, we do. We have the Frigo feeding pump, and that's available in the UAE.
Can Abound be administered NGT?
Yes.
Okay, I think 2 or 3 of the same questions. Can Beni protein be mixed with that? But like you mentioned, we don't recommend the mixing.
Yeah, and yes.
Okay. Nowadays, fat solution is not available for TPN and PPN. What can we do to compensate for that?
What is the question? Sorry.
Fat solution is not available for TPN and PPN.
Question for me or for another speaker, because I don't think it's related to
Yeah, exactly. Okay. So I think we covered most of the questions. They are a bit repeated. Can teenagers take it if they have low weight?
So the lowest age we recommend HMB consumption is 18 years of age, not because it will cause any harm, but because the studies that we have, the lowest age was 18 years, and we cannot recommend anything lower if we don't have any clinical studies that support that.
Okay, what about diarrhea?
So diarrhea is caused from numerous things. It doesn't have to be from the supplement. And it could be from the supplement. The patient might not tolerate the feed. They might have, osmotic diarrhea. In this case, we would recommend shifting them to maybe a formula that's, near isotonic with a lower osmolality, or shifting them to a partially hydrolyzed formula so that they have a better GI tolerance. But there are a lot of numerous factors. The diarrhea could also be from medication, from antibiotics, from the medical condition. So it doesn't necessarily need to be from the supplement itself.
Okay, thank you very much for that. We're having a lot of questions, but we're running out of time. If anyone has any more questions for any of our speakers for tonight, you can directly email us on ecns@mci-group.com, and we will be addressing each question to each speaker for tonight. Thank you again for all our speakers. Thank you again for Abbott for sponsoring this wonderful, educational, interesting webinar. And the CMEs will be available in 14 days. Be sure to fill out the evaluation form that will be sent out to your email ID, which will enable you to obtain the CME credits. And we are looking forward for our next upcoming webinars on 29th of September on cow's milk protein allergy, and 20th of October on diabetes and weight loss management. You can register for these webinars, and we will hope to see you all again. Thank you again, our speakers. Thank you again, our attendees. Have a great night. Thank you.